Thank you very much for the introduction and also, of course, for the opportunity to speak here. So again, we are switching to adult cardiology, of course. So this should be working. No, it's working. Okay, so, and of course I was given the title, to talk about tricuspid disease, and this, of course, in adult cardiology means that we have to talk about tricuspid regurgitation, because acquired tricuspid disease is mainly regurgitation. Stenosis is a very rare disease in adults, of course, mainly maybe associated with carcinoid disease, but this again is very rare, and then also mainly a problem of regurgitation. And if we talk about regurgitation, then also at least the pediatricians among us or among you should know that, of course, then this means in adults that we talk about 90% secondary TR due to left heart disease and usually also pulmonary hypertension. And of course, what we've heard already, again, it's a little bit more complicated disease than maybe aortic stenosis, and there are a lot of entities that are summed up in this entity of tricuspid regurgitation, because in the end, many left heart diseases, etc., actually are the causes and drivers for right heart disease in these patients. So it's sometimes hard to lump all these patients into one group to give them a little bit of a defense, maybe. So again, let's talk about the background first. I'll give you some epidemiological data. And of course, we've known for many, many years, even though the tricuspid has been dubbed the forgotten valve for many years, that of course isolated TR is associated with a reduced outcome, but also it is associated with a worsening outcome in patients with heart failure with reduced and preserved and mid-range ejection fractions. Many trials have at least retrospectively analyzed this, and of course we know now that TR is not only innocent bystander in these patients, but actually a force that additionally reduces the outcome of these patients. But unfortunately, or fortunately, you may start out with, you can say, well, surgery is there, and we know that it may improve survival, but you have to look very closely in these very rare trials that have been actually done in surgical patients, and this is actually one that is the basis for the recommendation for surgery in these patients, according to the new or last year published guidelines by the ESC, that patients should undergo surgery when they have tricuspid regurgitation. And you see that this is actually only a retrospective observation study with 500 patients included in the Cleveland Clinic, and the mortality was significantly reduced when patients underwent surgery. But you have to look closely, only 55 patients actually underwent surgery, so there's a huge selection bias, and you can only basically sum up that surgery is a possibility for these patients, but in only very selected patients. And this is also reflected in our statistics by the German surgeons. This is what they do every year in Germany, and you see you have to look with a magnifying glass for the tricuspid repair. It's only about 1% of all those valve repairs that the surgeons also, together with the cardiologists, one must say, do in Germany. So it's rare. It's a rare surgery to be done, and the reason for that is basically shown here. The problem is that even if you select patients very well, then you may expect a better outcome than doing nothing, but you still have to tell these patients that they have to expect quite some morbidity and unfortunately also mortality, especially in the group that we see the most in the adult world, which is the group that is struggling with left heart disease and has been repaired previously. So basically, you have the option, but it's a very limited option for a very limited number of patients. So is this a problem? Yes, this is a huge problem, because if you have a look at heart failure patients in Germany or in Europe in general and look for the degree of tricuspid regurgitation that you actually see if you do an echo in these patients. This is a registry data from about 1,000 patients that we enrolled at the Charité. You see that about 18% of these patients have at least severe tricuspid regurgitation, and if you scale this up to the patient number of heart failure patients in Germany, then you should have about 4 out of 500,000 patients in Germany suffering from severe tricuspid regurgitation alone. So of course, this is a huge number of patients, and of course, these patients have been undertreated over the last decades. So this brings us to the options that have been developed over the last years, and there have been many, many ideas, many concepts, and many approaches. So for the sake of time, of course, I will not address all of these, but there have been very inventive cardiologists and technicians who really tried to tackle this problem, of course, driven by the success or motivated by the success of TAVR and mitral valve repair. So what are the true available options that we actually use and have established in the clinical routine now? And this is, of course, the transcatheter edge-to-edge repair. It's a form of leaflet approximation. And the percutaneous annuloplasty. In terms of numbers, of course, this is much less used in Germany than the edge-to-edge repair right now. Also available, but really rarely used, is the option of heterotopic valve replacement by putting valves into the vena cava superior and inferior. The trick valve is now CE marked and can be used in these patients, basically doing ventricularization of the right atrium, and this can be successful in some patients, but again, it's also rarely used, and usually, as you can see here, in more or less failed attempts of tricuspid repair. What is not available right now, and we actually had hoped to receive the CE mark for the Edwards Evoque valve in the summer, but it has been postponed. Unfortunately, the regulatory bodies wanted to see more long-term data, apparently, but it should be available soon, hopefully by the end of this year, maybe next year, and this will be the first available valve for actually orthotopic valve replacement of the tricuspid valve, but many other companies have tried to tackle this problem as well and developed a huge number of valves that are currently under investigation, but I think Evoque will be probably the one that will receive the CE mark first. So what's the evidence actually for doing what we're doing right now in Leipzig, of course, but also in Berlin? And this is trying to repair tricuspid valves. And there is very limited randomized data, one must say. So most of what we are doing is based on registry observational studies, usually propensity score matched, something like this TriValve registry published a couple of years ago, which showed that if you compare propensity score matched pairs of patients that underwent TTVI, an intervention of the tricuspid via transcatheter means or standard therapy by medical therapy, then you see an benefit regarding overall survival, but also freedom from heart failure hospitalization. So these early data gives us hope that what we are doing is actually the right way to go for these patients, but of course we need randomized data, and a lot of trials are currently ongoing with a couple of different commercially available devices, and I think these will be very interesting to see regarding outcome for these patients. So given the limited data that we currently have, this is the weak recommendation that we saw in the guidelines last year. Only 2B, evidence C. So you may try to help these patients in heart valve centers if they are inoperable. But as you saw, most patients can be basically called inoperable because you have to see a very, very healthy young patient to be convinced that surgery is a good option for them. Okay, so what is the basically non-randomized data that these devices that are now established in the routine are based on? So we have the Triluminate trial, which of course was done by our chair today, and this is a single-arm trial, 85 patients, which used the TriClip device, and this is what you can expect in these patients, and this is also what we see in the clinical routine. About 71, maybe 80% achieve a result of TR reduction to grade 1 or 2. And this translates to a significant decrease in symptoms with an improvement of the NYHA class, and also, of course, this also translates to a reduction to heart failure hospitalizations and to an improvement of the 6-minute walk test. So these patients are better off, but again, this is non-randomized data. Similarly, this is the trial that first analyzed the outcome after cardioband implantation, which is the option for percutaneous annuloplasty, and again, this also resulted in about 76% reduction of TR to grade 1 or 2, and this was also associated with a significant improvement of symptoms. And also, 6-minute walk test improved significantly in quality of life. So again, single arm, no randomized data, only 30 patients, but the trial gave hope that this is a good option, at least for patients that have a good anatomy and are amenable for annuloplasty. And last but not least, the TRISCEND trial, the most recent of these trials, again, a single-arm trial, only 56 patients that analyzed EVOQUE. And this was, again, very promising because device success was very, very good with 98% median length of stay in the hospital for these very sick patients, only 3 days. Cardiovascular mortality was very low compared to the surgical results, and the mean gradient in the low-pressure system of 3 was very good. And again, this also translated to a very good outcome for these patients regarding symptoms and also an improvement of 6-minute walk test and quality of life as measured by KCCQ. So again, very similar results for all these different options. So what do you do actually when you see these patients and if you have these options available? Again, EVOQUE is not commercially available right now, so currently we are all tackling these patients with the edge-to-edge repair or percutaneous annuloplasty, and you have these maybe a little bit complicated algorithms, but in the end, you simply look for the best option regarding anatomy and overall, of course, patient characteristics. And I brought you 2 cases to maybe illustrate this more easily, and it's probably more fun to do that than going through the algorithm with you. So the first case is an 82-year female, in New York Class 3. She has peripheral edema, of course, NT-proBNP is severely elevated. She has massive TR, grade 4. And she also has, of course, left heart disease, hypertrophic cardiomyopathy with mildly reduced LVEF. She had been resuscitated a couple of years ago and received an ICD to prevent sudden cardiac death because the reason for resuscitation was ventricular fibrillation. And of course, as almost all of these patients that we see, she is in permanent atrial fibrillation. So what did we do? Of course, the first step is to analyze the anatomy, and as I said, she had an ICD in place, so you look for ICD lead interaction with the tricuspid, usually by TOE, and then in the transcatheter views, and you see that the lead actually is not the fault for the TR, it's innocent, it's not attached to any of the leaflets, there's no impingement, it's quite centralized, so this is not a huge problem. But if you look for the reason, the pathology or the mechanism for the TR, you see clearly it's a case of annular dilatation with a central depth, no tenting, no tethering, and this is what we would call atrial functional tricuspid regurgitation. Usually, this is a consequence of a long-standing AFib in these patients. So what we did was a cardioband implantation. Again, this is percutaneous annuloplasty, and the idea is that you place a band, usually by screwing in some 17 anchors in the case of the largest band available, which is what you usually need because, well, the anatomy or the TR is usually driven by annular dilatation, so almost by definition, you have very large annuli in these patients and usually go for the F band. And then using some skill on some patients, you put in these screws over the course of about an hour, and then you finish this C shape from the anteroceptor to the posteroceptor commissure. And then using a second tool, you can shorten the wire that's going through this band by pulling it into this spool. And this is shown here in this little cartoon prepared by the company, of course. And you see then the idea is to do basically what surgeons do. And of course, this is what we usually do as cardiologists. We steal the ideas of the surgeons and try to copy them by transcatheter means. And this is the idea here also. Of course, we try to do an annuloplasty not by putting in a ring, but by putting in a band that can be shortened. And these are some intra-procedural images from the very same patient. You see what you have to do, of course, is put these anchors very close to the hinge point of the tricuspid and not too close to the RCA, which is in quite proximity usually to the hinge point. And then you screw in the anchor and you do a push-pull test to make sure that it's really tight and safe. And then after, again, usually some 60 minutes, you have placed 17 anchors, put in the last one here close to the coronary sinus, and then you can shorten the band, again, as I've shown you, by basically pulling it into the spool, and you see quite clearly that the distances between these anchors goes down significantly. You do usually stress the RCA somewhat, but this is usually only temporary and not a problem for these patients. And then you see these results, and this is the 1-year follow-up already. So this is also our experience when you have a good result in the first minute, and it usually stays the same for the next month or years to come. So again, I said this is actually the option that is rather rarely used for different reasons in Germany. We do about 30% of our cases by cardioband, I think. But I think the predominant option right now that is edge-to-edge repair. So I brought a second case for you to see. And this is, again, an 81-year-old female, and you have 3. They are almost all in this age group. And she has also massive TR and was hospitalized with decompensated heart failure and had a couple of comorbidities, of course, not a surgical candidate. So again, we did an analysis of the anatomy. And also, actually, this was also mainly atrial functional, but she had also some mild STL prolapse. So we decided to go for to analyze actually both options. You see in the transgastric views quite clearly that there is a large central defect, and we actually thought, well, this is probably amenable for both annuloplasty and edge-to-edge repair. So we did the CT scan, as we do in almost all of these cases, and then you have this virtual implantation of the cardioband with some analysis if the anchors are actually too close to the RCA to make it a safe procedure. And you see, for instance, this is anchor 2, or the position for anchor 2 that is planned here in this CT, and this is a safe area between the RCA and the leaflet. But if you go closer to the posterior or the inferior part, then it's getting too close in this patient, so we decided to forgo annuloplasty and go for edge-to-edge repair. And this, again, is a little animation provided by a company, and this is the idea. Again, this is not a direct annuloplasty. Usually you see also a reduction of annulus size, but the idea here is to approximate the leaflets by catching them. Usually we do this now separately, as shown here, and then by closing this clip device, you have the opportunity or the ability to reduce the gaps between the leaflets and therefore reduce the tricuspid regurgitation as well. Okay, so this is, again, an image from the procedure. Again, this is a transgastric view, so you have the septal leaflet, the posterior leaflet, the anterior leaflet, and you usually start out in the anteroseptal leaflet and position the device. And then depending on visibility and patient anatomy, you either grasp the leaflets in the transgastric view, or for you it's probably easier to understand what we are doing by these mid-esophageal images, where you see that we are catching the anterior leaflet here, and as you see, the septal leaflet is not caught yet, and this is a major advantage of these newer generation devices, that we are able to grasp the leaflet separately, and the second grasping here is then the septal leaflet. And afterwards, you close the gap or close the device. This is, I guess, shown here. Yeah, it's closing, and you see the approximation of these leaflet edges, hence the name edge-to-edge repair. And as you see, this is usually not enough. In massive and torrential TRs, you usually need 2 devices, and this is then usually placed in the posterior commissure in standard anatomies. And of course, I shortened this a little bit. The second one is in place already, and you see a quite very reduction. And this is also shown here in the follow-up compared to the baseline images. So to sum up, there's very limited, mostly non-randomized data currently, which suggests a well-defined benefit for TTVI, but we need RCTs, and they are ongoing. Edge-to-edge repair and percutaneous annuloplasty are established options, again with huge numbers now in Germany regarding edge-to-edge repair, and rather few numbers of percutaneous annuloplasty, one must admit. And we all hope to see, especially in very challenging anatomies and torrential cases, which can be quite hard to treat with these devices, to see the opportunity or the option to do a valve replacement with EVOQUE and similar devices that should be available over the next 1 or 2 years. Thank you very much.
Thank you for a fantastic overview. Are there any questions from the audience? we're a little bit short in time. Maybe one quick question and a quick answer. Do you think that, given that repair is a little bit more complex and replacement probably will be easier, do you think that replacement in the future will be the main thing we do, the gold standard, and will, in most cases, replace repair?
I hope not, because I think repair is more fun, right? No, honestly, I think I mentioned already that we usually steal the ideas of surgeons, and usually surgeons try to repair, and for a reason, because hemodynamics is better, there's less thrombosis, and I think it's a safer procedure overall. And if you're as close as the normal anatomy as possible, I think that's the best way to go. This is why we usually start off with a cardioband evaluation, and if there's a reason to go for to not do it, then of course we go for edge-to-edge repair, because usually there's annular dilatation, and if you can just reverse this and the TR is gone, then usually this is the best option for the patient, at least from what we saw. And so I also think that putting a valve in is usually not the best way to go, especially regarding hemodynamics. But well, let's see.
Yes, please.
Is there experience regarding explantation of the cardioband with these screws in the annulus? Is it possible? Or?
It's possible. We haven't seen it in our institution, but from what I've heard, it's possible. I think there have been a couple of mitral cases that had to be repaired by surgeons afterwards. And so it's possible, but it's usually not something that, I mean, we never had a case where it should have been done or where there was an indication. And I think, again, the patients that we see, usually nobody touches them surgically.